Hello everybody, nice to see you again. Let's enjoy the chest radiographs with Dr. Y, session 29, inactive tuberculosis, stable tuberculosis, session 3rd of the 3. Hello everyone, how about the last session about the active tuberculosis, diseased state of tuberculosis? Was it interesting? I hope so. Let's go to the last session of tuberculosis, inactive, stable TB. Let's go. I repeat again this slide. We remember this slide, but I repeat again today because this slide is the most important slide about pulmonary tuberculosis, written by Dr. Nachapan et al., Pulmonary Tuberculosis in Radiographics, year 2017. First, cavity. Second, consolidation. 3, tree-in-bud pattern. In other words, centrilobular nodules. 4, miliary nodules. 5, lymphadenopathy. 6, pleural effusion. These 6 findings strongly suggest us the lesion the patient is ill with pulmonary active tuberculosis. Radiologic findings of inactive tuberculosis, also written by Dr. Nachapan, Tuberculosis, Radiographics, year 2017. I also repeat again the inactive findings, actually stable findings. Number 1, peribronchial fibrosis. Number 2, well-defined nodules. Number 3, traction bronchiectasis. Number 4, upper lobe volume loss. Number 5, calcified granulomas or calcified lymph nodes. I, Dr. Y, simply say again, inactive finding is actually without active findings. Without active findings usually means stable tuberculosis. Radiologic findings of stable tuberculosis, stable pulmonary tuberculosis. Radiologic stability, in other words, no change. We are very familiar with these words. No change for 6 months, more than 6 months, and negative sputum culture is the best indicator of inactiveness of the pathology. Descriptive terms, the inactive or old should be discarded in favor of radiographically stable tuberculosis because as viable AFB may persist despite the treatment. So the term stable is better prepared than the words inactive or old tuberculosis. We have met these 2 pictures before in the previous session. Please look at right upper lobe pathology. These lesions had not been changed for a long time. Stable, still stable. But how about the left upper lobe lesion? This hasn't been changed, but recently has changed very much. Stable TB lesion became active lesion. We do not know whether this is reactivation or reinfection tuberculosis, but we do know that this lesion is post-primary tuberculosis, active lesion. Stable findings does not guarantee no reactivation nor reinfection tuberculosis. At any moment, According to patient's condition, it can change into reactivation or reinfection tuberculosis, post-primary active pulmonary tuberculosis. Let's study the real cases of stable tuberculosis, middle-aged woman. Several years before is on the left side. First, let's look at the hilum. What about the hilar structure, anatomy, and position? Right side is okay. Left hilum is more elevated, and the hilar structure, pulmonary arteries, is slightly deformed. And what about the left upper lobe apex? Crowded, more densities than right side, with nodules, well-defined nodules. Although left side film quality is poorer than right side, we can identify these abnormal findings. This is fibrosis, calcifications, and you can find that it has not been changed for several years. Elevated hilum, deformed bronchus, peribronchial fibrosis, well-defined nodules with some calcifications. Please look at the normal right upper lobe, normal right hilar structure. Yes, left side is different with normal side, but has not changed for several years. This is no change more than 6 months. Stable tuberculosis. This old woman's chest radiographic findings hasn't been changed for more than 6 years. What's wrong with her film? Yes, right hilum is not looking good. Elevated very much, very higher than the normal left side. And also right diaphragm is elevated. Trachea is deviated to the right side, and this is minor fissure, so right upper lobe is collapsed with many well-defined nodules with some calcifications, peribronchial fibrosis in left upper lobe, right lower lobe calcified nodules, traction bronchiectasis. Yes, this patient shows everything about the stable tuberculosis. Not has been changed more than 6 months. Peribronchial fibrosis, well-defined nodules, right upper lobe volume loss, calcifications. Stable TB findings. Let's repeat again the findings of stableness. No change for more than 6 months. No change for 6 months. Peribronchial fibrosis. Fibrous streaky density of peribronchial fibrosis. Well-defined nodules. Well-defined nodules. Traction bronchiectasis. Traction bronchiectasis. Upper lobe volume loss. Upper lobe volume loss. Calcified granulomas. Calcified granulomas. How about this young man? No change for more than 6 months. Let's look at closely. Hilum is normal. Left pulmonary artery is normal, right pulmonary artery is normal. But we see many well-defined small nodules with calcifications, fibrous streaky densities of peribronchial fibrosis and traction bronchiectasis. Not like right upper lobe, but left upper lobe is very crowded with stable findings. It hasn't been changed more than 6 months. This is stable pulmonary tuberculosis. How about this old man's film? Right hilum is deformed and elevated. Minor fissure is deformed and elevated, and trachea is deviated to the right side. All these findings means right upper lobe volume loss, decreased right upper lobe volume with bronchiectasis here. and many pleural thickening. This coronal lung window setting shows everything. Right side main airway was deformed and elevated to the right upper side. Minor fissure is elevated, bronchus is thickened and dilated. These are traction bronchiectasis, pleural thickening, cystic change, fibrotic change, peribronchial fibrosis. This is stable findings. How about this old man? His both hilums are looking good. Both sides are normal position, normal looking descending pulmonary arteries, normal looking trachea, main bronchus, lower bronchus. And diaphragms are looking good with a normal peripheral lung on both sides, but with only this one, 1.5 millimeter calcified nodule. This nodule is calcified. This is calcified granuloma. Have you ever seen this kind of image findings? He is an old man. His spine is deformed and left upper long jaw does not looking good. Several lips are retracted or not visible here, not original form, and left upper long jaw was collapsed. His right side is okay. Right side diaphragm, right side hilum is okay, and left lower lobe seems to be relatively okay, but upper long jaw is very deformed and collapsed. It was the name of surgery, thoracoplasty, a kind of primitive surgery when medical facility was not available. When we were poor, without medicine, we sometimes have done this kind of operations, thoracoplasty. It is an operation removing selected portions of ribs to collapse the underlying lung or underlying abnormal pleural space, especially for treatment of tuberculosis. We do not do this kind of operation anymore. How about this middle-aged man's film? 3 centimeter dense mass in right upper lobe. What else can we see? Yes, left hilum is elevated, and there are many well-defined small nodules with calcifications in left upper lobe. And the left side diaphragmatic pleura is thickened and deformed. And also we see the left side lung is smaller than right side and deformed with smaller intercostal space than right side. He's been same for a long time. For a long time it has not changed. On his actual non-contrast enhanced CT, we find these calcified mass, calcified nodule, and several calcified nodules on left side too. And this is a stable tuberculosis with calcified mass form. How about this middle-aged woman? Her left side is looking good. Normal diaphragm, normal peripheral lung, normal pulmonary artery, normal left bronchus, left main bronchus, left lower bronchus. So her left side is gold standard for comparison of right side. What's the difference? Yes, right upper lobe shows inactive, stable tuberculosis findings. Yes, everything about stable tuberculosis findings. Right hilum is slightly deformed and elevated. Right diaphragm is elevated and flat. deformed pleural thickening. What about this? Yes, please look at this magnified image. This is almost linear pleural calcification with fat density here, and this is extrapleural fat, thickened extrapleural fat. This means this is very chronic process of pleural inflammation after tuberculosis pleurisy. How about this old man? Right side lung is relatively looking good. Relatively, not 100% okay, but relatively looking good. How about the left side? Yes, all stable TB findings here. Stable TB findings, calcifications, thickened diaphragmatic pleural with pleural calcification, linear and broad, anterior or maybe posterior. Let's look at the CT. Yes, it was posterior location. Pleural thickening after chronic process of pleural inflammation. This is thickened fat of extrapleural fat. Yes, after chronic inflammation of tuberculosis pleurisy. She is a middle-aged woman. Left hilum does not looking good. Right side is normal for comparison of left side. Left hilum is more elevated with deformity, with many calcifications, well-defined nodules, peribronchial fibrosis. Left side diaphragmatic pleural is looking good. Let's look at the axial non-contrast CT. Yes, fibrosis with multiple well-defined calcified nodules. How about the lung window setting? Fibrosis, calcifications, traction bronchiectasis, volume decrease. We sometimes say about the healed cavity. Cavitation usually means active tuberculosis, but we sometimes see some cavities, very thin-walled cavities after treatment with stable feature, no change more than for 6 months, without active disease findings. This is healed cavity of stable disease. This is coronal image. Traction bronchiectasis with deformity, but thin-walled cavities here, without findings of active disease. This is, we sometimes meet and say, healed cavity. So it is relatively stable findings. And the bronchial tuberculosis. After treatment of parenchymal pulmonary TB, there sometimes remains a sequelae of airway disease of tuberculosis. Let's look at this radiograph. Trachea looks okay, and right main bronchus intermedius looks okay. But how about the left main bronchus? It isn't so looking well. Deformed or narrowed? Let's find out. Let's confirm with the coronal lung window setting. There is a findings of narrowing deformity of left main bronchus here. This is the sequelae of endobronchial tuberculosis, deformed and narrowed. We do remember the name, the dangerous name, superior sulcus tumor. One of the patient is superior sulcus tumor. Which one is superior sulcus tumor? Left side person is older than right side person. The findings are very similar here and here. This is a magnified view of these two patients. Which one do you believe has superior sulcus tumor? Yes, right side. This one is superior sulcus tumor. This one is tuberculosis scar. We have usually two clues of superior sulcus tumor. The pain of the patient is so severe in superior sulcus tumor. And the radiologic finding is rib invasion, rib erosion. You can see here the lower margin of the second rib is not clear here. Third rib is clear, okay. Second rib is clear here in this person. This person is clear with rib structure. This is tuberculosis scar, and this is superior sulcus tumor. How about these two other cases? Left side is man. Please look at his right apex. Right side is woman with deformed breast after breast operation. Please look at her left apex. Yes, left hilum is elevated. Right hilum is normal. Right upper lobe is looking good, but left apex does not looking good. Thickened pleura with fibrosis, peribronchial fibrosis, traction bronchiectasis. Right side is also similar with the other side. Right hilum is elevated, right apex is deformed and collapsed with pleural thickening. What are the causes of these two different radiologic same findings? This is also the magnified view. Right side is from tuberculosis, sequelae of chronic tuberculosis of right upper lobe. He is now okay because it is stable. How about the left apex of this woman? Yes, this is from the chronic radiation pneumonitis for left axillary lymphadenopathy from breast cancer. This is post-radiation change, chronic radiation pneumonitis. But findings are almost same. We cannot differentiate which one is which from what disease. Same findings of different origin. This is a quiz for you. Which lobe is not looking good? Not visible. How about left upper lobe? Is it there? How about left lower lobe? Is it there? How about right upper lobe? How about right middle lobe and right lower lobe? It is interesting. Please look at the airway, large airway. This is trachea, and left main bronchus, left upper, left lower bronchus is okay. Right main bronchus is shorter than imagined. Bronchus intermedius is here. But how about right upper lobe bronchus? This one, shorter, thickened, dilated. Yes, this is right upper lobe bronchus, collapse, right upper lobe collapse and traction bronchiectasis after tuberculosis. Also, left side shows the stable TB findings here. This case is representing right upper lobe collapse here. Hilum is elevated, and right side pulmonary bacillars are very smaller than usual, very scarce than the left side. This means there is something volume loss of right upper lobe. Now this is very, very easy for you. What's this? What's his chest radiograph represents? Yes, right upper lobe collapse. We know this one. Right hilum is elevated. Right diaphragm is elevated. Right side pulmonary vessels are smaller than left side. And right upper side is very dense, denser than before. And surely this is elevated minor fissure with calcification, bronchiectasis. Let's compare with coronal non-contrast CT. This is dilated bronchus filled with secretion, bronchiectasis, and distal calcifications. This is also fluid-filled bronchus. We used to say this as fluid bronchogram, right upper lip collapse after tuberculosis. Several years before, her chest CT showed these features: large cavity, many consolidation, twin-bud patterns, twin-bud branching patterns of active tuberculosis. Now she shows healed, stable tuberculosis findings. Let's suppose right side is normal. Right side is looking normal, and this can be a gold standard for comparison. There are many calcifications, well-defined nodules of calcification everywhere on the left side. And left side lung is looking darker than the right side with smaller pulmonary vessels on left side. And this suggests volume loss in left side. This is stable tuberculosis after treatment of these findings several years before. We are now familiar with active findings of pulmonary tuberculosis like these, and stable findings of tuberculosis. This is stable, not changing for more than 6 months. Lymph node calcifications are another clue for the stable tuberculosis. What do we see here? Calcified rim, calcified rim, calcified rim, calcified rim. All lymph nodes are calcified with rim calcification. In this axial non-contrast CT, we see these egg-shell-shaped lymph node calcification. It also suggests stable tuberculosis. When can you see these kind of axial calcifications more? What is the name of other disease? The names all ended with osis: tuberculosis, pneumoconiosis, silicosis, amyloidosis, and sarcoidosis. All shows these kind of eggshell lymph node calcifications. This slide shows the chronic tuberculosis empyema. We sometimes interchangeably use the term fibrothorax for these findings, fibrothorax or chronic TB empyema. Let's look at the chest radiograph. Right side is looking good. This is gold standard for comparison. What happened to his left side? Yes, left side thorax is smaller than right side. An apical pleural thickening with calcifications and very large pleural thickening with dense material with peripheral calcifications. This is chronic tuberculosis empyema. Let's see on the coronal non-contrast CT. Yes, this is chronic inflammation encircled with pleural pleura, with parietal pleural and visceral pleural calcifications. This is chronic empyema or fibrothorax. This is axial view. Visceral pleura and parietal pleura or encircling the chronic empyema. Let's look at the left side film of this middle-aged man. We remember this film in the previous session as the name tuberculous pleurology. This effusion was drained and he was well treated and stable now. How about the right side film? This film we remember as chronic empyema or fibrous thorax in previous slide. Let's presume if the left side man does not treat it well, what will happen to him? Probably, surely, this lesion will go to this fibrothorax or chronic empyema of calcified pleura. This is the last slide of stable pulmonary TB and also actually the last slide of pulmonary tuberculosis, and also is the last quiz for you. I expect and also respect your correct answer for this case. Her left side is looking good, left side lung is looking good, left hilum is normal position, normal posture, normal size. How about her right side? Her right hilum is smaller than usual, smaller than her normal left hilum, and right paratracheal bulging, obliteration, and her right upper lung zone pulmonary vessels are smaller than left upper pulmonary vessels. Now it is getting clear for you. Let's approach in the other way, second way. Let's look at her large airways. Trachea is looking good. Left main bronchus, upper bronchus, lower bronchus is all looking good. How about right side? Her right main bronchus does not looking good, not clear, but at least her bronchus intermedius is here. How about her right upper bronchus? Not visible. I cannot find out the right upper bronchus. What is your answer? What is this one? This is not a mediastinal tumor. Yes, correct. Your answer is correct. I respect you. You are now, and I salute you as the master of pulmonary tuberculosis. I respect you. Congratulations for your finishing and mastering the pulmonary tuberculosis. Like, subscribe will be a big support to Dr. Y. Thank you very much and have a good weekend.